From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners around the world. You're listening to JAMA Oto Author Interviews. Thanks for joining us. I'm your host, Dr. Paul Bryson, Director of the Voice Center at the Cleveland Clinic and Section Head of Laryngology. Today, I'm joined by my colleague, Dr. Leila Mady. She's an assistant professor of otolaryngology head and neck surgery at the Johns Hopkins School of Medicine. Welcome to the podcast, Dr. Mady.
Thanks, Dr. Bryson, and to JAMA Oto for having me. Really enthusiastic about this opportunity.
Well, I'm delighted to have you on. I feel like many years ago, we were aware of your interest in financial toxicity and quality of life in our patients with head and neck cancer. And so I think this is pretty special over the years to return to an investigator in a topic that has been a passion project for you for many years. And we will have you share with us the long-term findings, this longitudinal financial toxicity and quality of life in patients with head and neck cancer. So I wanted to say congratulations on the work.
Thank you.
Well, if you would, can you take the listener back and tell us a little bit about the motivations for the work? And then one of the really interesting and important things for this work is really the methods for the project. So if you would, just give us some background and tell us about this.
Absolutely. Probably helpful to start and make sure that we're all speaking the same language and start with maybe just a basic definition of what financial toxicity is. It's a term that's used a lot in the literature or even in the media in terms of the costs of cancer care. So just to start, financial toxicity broadly tries to encompass the objective, the subjective, and the behavioral patient level impact of the costs of cancer care. So it's really trying to describe the totality of the experience related to the financial burden of care. And some of the terms that are associated are financial distress or financial burden. So to start on that page. And like you said, this is really something that started years and years ago, back really the work on financial toxicity and head and neck cancer in 2018 when I was a resident at the University of Pittsburgh. And we started there with some cross-sectional analyses, just looking at a cohort of patients across different time points, not necessarily a consistent time point for treatment, and just try to get an understanding of the landscape. And from that initial work, then moved to designing a prospective, longitudinal, multi-time point study that not only incorporated survey data, but also incorporated qualitative interviews that was matched with patients' caregivers. So really a dyadic, prospective, longitudinal, multi-time point study to really get into a deeper understanding of what was going on over the treatment trajectory in terms of the financial toxicity of treatment.
And, just again, for the listener, like you said, this is surgeon or caregivers and patient and involves not just survey data, but also interviews over time.
Mm-hmm. So we designed the study to have surveys that were conducted at diagnosis, at 3 months, and at 6 months after diagnosis. That included a repertoire of surveys geared for patients, but also a repertoire of surveys geared for caregivers. And some of that work has been previously published in JAMA Otolaryngology, describing the caregiver burden experience of patients with head and neck cancer. And this work is an extension of that. This was all part of one massive research study. And so we took surveys sequentially at these different time points to understand how dynamic changes in quality of life and financial toxicity occur over time. And the interviews occurred at the end of the study period to then be able to reflect on lessons we had learned from our cross-sectional work to really, again, dig deeper into some of the patterns that we were seeing that were being reported in the surveys.
What were some of the highlights of your findings?
We had 100 eligible patients, and in the end, we had 64 that were included in the analysis. And among the 64 patients, 43 had enrolled caregivers. So 67% of our population had caregivers present. And overall, what we saw just in terms of general demographics, a predominantly male population, which is what you would expect for head and neck cancer, but some basic demographics that we saw from our population is that the comprehensive score for financial toxicity, the cost score, which is one of the most utilized surveys for financial toxicity, the baseline score was overall a median of 17, which is, when you look at the financial toxicity literature, lower than what some thresholds place at 26 for defining some amount of financial toxicity. So the overall population had a median cost score of 17, predominantly education levels that were lower, an associate degree or less, and most patients that had Medicare or employer-sponsored insurance. So that was some of the initial demographics that I do think sets up the stage from some of the important findings of the later work, which I can go into if that works.
Please do. Yeah, share the highlights. I'll encourage the listeners to read the manuscript too.
So some of the just key findings. First, we saw some parallels between patients and their caregivers. Patients and caregivers reported similar levels of feelings of support and loneliness. I think another novel finding of this work is that caregivers' reported financial toxicity was similar to that of patients' financial toxicity. So they mirror one another, which was not reported previously in terms of the financial toxicity literature, especially in head and neck. And then we saw some longitudinal changes in financial toxicity that are associated with education levels and with employment. So overall, patients that have higher education and are of older age have lower reported financial toxicity, while those that have lower education and are not working have worse financial toxicity over time. So I think that highlights the role of employment and education in potentially mediating some of the effects of financial toxicity. And then some of the qualitative interview findings really highlighted some of the themes we already know about financial toxicity in terms of direct and indirect costs that are associated with how patients experience financial toxicity. But I think what was striking and one of the more emerging themes, I think, associated with financial toxicity was the mismatch in treatment expectations that patients and their caregivers had in terms of being prepared for not only the cancer journey, but the financial demands that accompany your treatment. And that was a really striking finding that had not been really teased out from some of the cross-sectional survey data that had been conducted previously.
And it's a real challenge, right? I think as surgeons and providers, we try to spend time, think about it at the time of diagnosis, just trying to, breaking the news, putting a treatment plan together, talking about functional outcomes that you hope for, right? And preservation of function or mitigating functional loss. It's hard to know, where does the team put the financial implications into this whole big, massive event that the patient and their family is going through.
And you bring up the point, who is bringing up the financial implications, right? There are all sorts of ethical questions or concerns that surround who's supposed to have this conversation with patients, who do patients want to hear this information from, which is a whole other area that we're looking into with one of the co-authors on this paper, who's a senior author, Dr. Garze. Her and I are working on really screening preferences and best practices for screening. But you do bring up that point. It's really hard to pack this all in when you're trying to break the news to somebody about cancer treatment. And I wish I could have a manual that's what to expect when you're not expecting cancer, basically, to be able to provide sort of a handbook of all the other things that we don't get to talk about, which is what you're referring to.
When we think about just trying to provide not just the most effective care, but maybe the most empathetic or You're at a large healthcare center that provides all of the resources. You wonder, right? Where does it fit? How can we take care of the patient in every way that we can during a cancer diagnosis and treatment? It's very provocative is that we try to put together not just care pathways, but I guess maybe the journey, if you will.
And even at well-resourced, right, tertiary care institutions, trying to implement screening and management of the financial burden and associated opportunity costs of treatment is really, really challenging. And so to take this setting and try to replicate a model for addressing this in the real world, right, or community practices where this work is also necessary, I think remains a challenge. And this is why work like this is driving towards models that are really real world. That is the ultimate goal, is how do we develop pathways and interventions that help all patients with cancer, not just patients that are seeking care at large practices.
Well, I want to congratulate you on the work. As this makes it to publication, what are some of the future initiatives or lines of inquiry that you're excited about?
One thing to take is something that everybody can do is the first step, trying to raise awareness about just the impact that financial toxicity can have on patients. Is you as a provider and the care team members can all do are simple things like ask patients what they do for work, ask patients how scheduling appointments or different treatment centers, proximity to treatment centers can impact those other aspects that we don't really think about as part of the care pathway or the care plan. So I think that's one low-hanging fruit I'd like to encourage treatment teams to do and start to think of just those little things that you can integrate in terms of coordinating appointments or thinking about, how it can impact employment changes. And then from next steps, this work has taught us that really the context of the individual matters. And what I mean by that is that things like employment, things like access to transportation, access to credit, these other factors, the physical, financial, and social resources that somebody has can make an impact on their potential treatment adherence and success through treatment. And so what we're starting to do is really look into the resources and the context of seeking care. And I think that's exciting because those are touch points that interventions or health policy changes can be made in terms of tackling financial toxicity outside of the health system itself.
Well, I just want to congratulate you on this really important work. It's really great to see this at the end of many years of doing the project through the pandemic and things like that. So really appreciate your time coming onto the podcast today to talk about it.
Thank you so much. I look forward to more conversations in the future.
Yep, me too. I am Dr. Paul Bryson, and I've been speaking with Dr. Leila Mady about the longitudinal financial toxicity and quality of life in head and neck cancer patients and their caregivers. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.